Welcome to the session of the Health and Social Care Select Committee. Today is our 7th session in the Food and Weight Management Inquiry that we've been undertaking, and we will be looking particularly at diabetes and also bariatric surgery in panel 2. So without further ado, can I please ask our witnesses to please introduce themselves and their organisations. Can I start with Professor Roy Taylor?
Thank you. I'm Roy Taylor. In my consultant physician career, I dealt with acute medicine as well as diabetes and medicine in pregnancy. But all the way through, my main research thrust has been understanding what happens to food inside the body, how it's handled in health, during exercise, but of course in disease. And from my clinical point of view, the main disease was diabetes. That led to suddenly realising we had the cause of type 2 diabetes at our fingertips. To test that, I needed to develop an effective way of getting people to lose about 15 kilograms in weight using diet. And that has led to the whole series of studies and the remission programme.
Lovely. Thank you very much for being with us. Colette Marshall?
I'm the Chief Executive of Diabetes UK. We're a charity for people with diabetes that's been here for 90 years now, and we funded the research that Roy Taylor is talking about that, and then helped that translate into practice. I come from a corporate background and have worked in a number of charities. I've also worked for MEND programmes for children and young people who have overweight and obesity. I just want to declare 90% of our income comes from people with diabetes, but we do partner as well with Tesco, with Lilly and other providers of GLP-1s, and also with Slimming World in our work, all of which is very welcome but does not control any of our policy, nor is it something we're reliant on.
Much appreciated. Alex McIntyre.
Thank you very much. I should say thank you to the panel for the work you've done on this. So this first session is quite close to my heart because last year I was diagnosed with type 2 diabetes and I then went on the Path to Remission programme, losing around about 7 stone initially and putting my diabetes into remission, which is
Bravo.
Thank you. Testament to the programme. Professor Taylor, could you just briefly, for the committee and for the evidence, describe the Path to Remission programme and the evidence there is on its effectiveness?
Yes. To start with the evidence of effectiveness, this came about in testing the original hypothesis of what was causing the diabetes, and we were able to confirm having devised an effective way of getting 15 kilograms weight loss in the first week. Plasma glucose normalised because of a very rapid loss of liver fat, sort of current account of energy. That's where it's held, that's where it scoots out of when energy is scarce. And that understanding led us on to a series of studies, cumulated and direct, which led on to the Path to Remission. So the Path to Remission programme offers people under the age of 65 and with a body mass index over 27, but type 2 diabetes duration for less than 6 years, it offers them the chance of embarking upon this weight loss programme. Now, before the programme, they're advised that they should discuss this with their spouse and friends. That's a critical part of the whole business of making it successful, and invited to think about it very carefully. But then they embark upon 12 weeks of taking packet food only. Now, this has got the major advantage of being nutritionally complete, apart from the calories, and so there are no problems about protein deficiency, iron, whatever. And over that time course, we find that people do lose weight. The average weight loss immediately after the course tends to be around 15 kilograms, but at 1 year, it has dropped to about 10 kilograms. Now, indeed, when the Path to Remission programme was launched, I was just slightly concerned because we weren't using trained practice nurses who actually delivered direct with 8 hours of formal training. We were using people who didn't have any professional qualifications but were commercially employed to know about it and deliver it. But to my surprise and pleasure, the average weight loss was 10.3 kilograms at 12 months, which is remarkable for a population study. and almost half were in remission at that time. So the evidence is very strong. The evidence for persistent effect is also strong. At 5 years, we know that people are still 6 kilograms, 6.1 kilograms below baseline. Now that's quite different to, for instance, use of the GLP-1 agents with complete regain in about a year and a half. And it relates to the educational value of the
We're going to come back. We're going to come back to why,
right.
if that's all right. We can hold the. Yeah. Thank you.
So that outlines the programme and its effectiveness, which I think has now been established beyond doubt in several different countries as well as the UK. Thank you.
Thank you. And Colette, what are some of the challenges that people with diabetes face when taking part in the programme, and how are they supported through that?
So I think the first challenge is access. So the first challenge is that primary care is not fully aware. The second one is that, like the rest of the population, there is huge stigma about having overweight and having obesity, and therefore about having type 2 diabetes. So healthcare professionals reflect the rest of the population in that way. So we know from our research, many of them will not offer it either because they don't believe it's going to work, or because they think that the individual in front of them is a lost cause. So I think the first one is access. So there isn't data yet on the full cohort that could be helped. Welcome Foundation and AMRC did some work on this and said that if you look at just the inclusion criteria, 613,000 people should be offered remission, and at the moment we're reaching about 55,000. They didn't apply exclusion criteria to that, but I think it's very clear that there's a big step between what's been offered and what is the potential there. So that's the first one. Then the second one is actually being able to take up the programme. Our data shows that if people are offered a choice, and the choice is between having it offered digitally or offered face-to-face, that makes a massive difference to the number of people that then go on to do it. That sense of agency and being given the opportunity to choose how to take part is of itself of huge value. Then when you look at... Sorry.
On that point, the fact they've been offered two, or the fact that they've been offered digital and face-to-face, what is it? Is it one aspect of that, or the fact that they've been offered a choice?
I think it's the aspect of being offered a choice.
Choice, specifically.
So at that point, some people will decide that they are ready in that moment of time. And the reason they pick digital is either because they don't want the embarrassment or difficulty with dealing with an employer. They don't want to be saying to somebody, this is why I'm off work, so they choose to go digital, or because access to the location is difficult for them, or because digital is more readily available and they say they know that they're ready now, they need to go now. They don't want to lose that motivation.
Okay, thank you.
So that's...
They've just been elected to Parliament and don't know if they're going to be in Westminster or in their constituency.
They don't know where they're going to be. Yeah, that's so true.
On that point, is that choice? So I was offered that choice between digital and in person, and I chose digital for that reason. Is that not being offered then to... How many people is that not being offered to? Is that?
So if I look at the data, we found... Right, I might have to come back to that. We found that not everybody was being offered the choice. The other thing that not everybody is being offered is the peer support throughout the programme as well. So 84% who have it say it's very, very helpful, but only 56% are offered it. We found that some people will drop off the programme because they can't cope with the meal replacement. But in the main, 84% of people are saying they like the products, and also say that they're culturally appropriate as well, and that the coaches provide good cultural support. If the coach is consistent throughout, and if the person has a good relationship with the coach, that gives better results. People who struggle with their coach, and it's not many of them, but that is one of the areas where people find it harder. And then there's the whole sort of social aspect of this. It helps if your family and friends are supportive. And I think, Roy, you can talk to some stories about this, where we know that if the other caregiver in the family is not supportive, it is very, very difficult, because it's very difficult for one person changing how they eat if the rest of the family don't go along with it as well.
I could definitely attest to that. My wife was very supportive, although it didn't stop buying cakes and biscuits every week, sadly. But I managed to stay on the course. So going back to the first point. So on access, that's something that's come up in our roundtable with people who've experienced the scheme said there's a lack of knowledge from GPs in particular about the programme, and that's the same in my case. I actually had to ask my GP to go on it because I knew that my brother-in-law had done the similar programme for people who are pre-diabetic in Bristol. How do we go about? So why aren't we seeing GPs offering this out to everyone who's newly diagnosed, and what can we do to improve access to it?
The NHS is trying to help on this. They are currently commissioning all of these diabetes programmes under a single brand called Healthier You, and I think that will help. I think there is the issue of doing anything and the time it takes to embed in primary care, because one of the key messages I wanted to make today was, when stuff works, please don't change it. And I think this is one of the cases. There's something here that really works. We're the first country in the world to have a national remission programme, and we should be really proud of that. The question is, as you say, how do we scale it up? How do we make sure that local areas do know about it, call it off? How do we make sure we provide for more? So centrally these are commissioned and paid for, so we pay for enough places and then call on local systems to be really proactive about offering it.
So just to be really clear, that's being funded centrally then, not by ICBs?
So it's funded centrally and then ICBs call off. And I think that's another reason why this and the National Diabetes Prevention Programme, which is very similar but doesn't have the total diet replacement element to it, why they both work. And I mean, the National Diabetes Prevention Programme now has over 1 million people that have started it and has had 2.1 million referrals. So it has achieved scale. And I think you do that over time by making sure that, A, there's central purchasing. You make sure that the other thing that's worked really well is they have commissioned a range of providers. So local areas still have choice, but we don't end up, as we did maybe 10 years ago, with every local area inventing their own prevention programme. So these programmes have proper evidence base that they're built on. They collect proper data. The data is analysed to see what's working, what's not working, and then it's tweaked. We provide market research, so we go out to people with diabetes, people who've been through the programme, and actually bring back validated response about what's working, what isn't, and that's then fed in. And it's done at scale, and you get the economies of scale as well. So I think there's some huge learning here for other forms of weight management programme.
In terms of scaling it up, I mean, one of the biggest challenges with type 2 diabetes is the number of people living in the UK with type 2 diabetes diagnosed. How could the government go about improving that pathway so we're getting more people diagnosed and then straight onto this programme and working on towards a remission? What shift would the government need to do to be able to tackle that very high number of people who are living with undiagnosed?
There were 1.3 million people living with undiagnosed type 2 diabetes, which means they're not being treated. Now, if you go back to when I started at Diabetes UK about 13 years ago, you would have said that a fair number of those, and still is the case that there is a number, are in their elder years, when it is less medically or clinically risky. The issue we've got now is the biggest increase in the number of people with type 2 diabetes are in the under 40s, and they are presenting very fast with very high blood glucose levels, and their complications that you get from diabetes are coming on very aggressively, presenting very aggressively. So big risks in terms of cardiovascular health and a variety of other complications. So what we would like to see is much more, at the moment you have to wait to the age of 40 before you're going to have health checks. We would like to see those populations that are believed to be high risk, so Black African Caribbean communities, people from South Asian background, particularly women who've had gestational diabetes, we would like to see them being checked. So women with gestational diabetes who've got a very high risk of having type 2 diabetes, about half of them are not getting their postnatal check. So they are potentially, and I've met one of them who's spoken here in this house, one of them had gestational diabetes, was not then checked, had type 2 diabetes, went on to have a second pregnancy and then lost the child. So I think it is picking up these really high risk groups and making sure that they are checked for type 2 diabetes, and then, as you say, offering them the support of the remission programme.
Great, thank you. I think you might have seen, well, perhaps you haven't seen my New Statesman article about expanding health checks to the younger people with other risk factors just this week, which I'm speaking about later this evening.
Thank you.
On the behavioural support, we talked about, the support of family, but what support does the programme actually offer, particularly during the food reintroduction phase, to make sure that people stick to it and are able to keep that weight off?
That is provided by the individual companies. They are asked to see people frequently, I think it's every 2 weeks, and it's that support during that phase which is so crucial. Because it's that phase, which you must be aware, where people actually learn what they're needing to maintain their body weight. Now, before they start, I hope you're advised to expect to eat about 2/3 of what you would habitually eat once you'd become a smaller person. Smaller people need less food. That's often dressed up in silly scientific terms as change in metabolic rate. Well, of course it's change, but it's a very simple reason. So the prior expectation, coupled with the frequency of visits that should be provided by the companies providing the care, should put that in place. And I would add that the companies are paid by results, by delivering the various bits of information. I don't know the details of what information is required during the food reintroduction phase, but I would hope that that would be a positive feedback to the company to ensure that reasonable care was given.
I guess, the data shows that about 1/3 of people drop off after the first 12 weeks. They go through the total diet replacement, and I think quite a high number past that, but then 1/3 of people who go through that then drop off before the end of the year-long programme. And I guess that aligns with my own experience of the programme, which was it's quite easy to motivate yourself when you are, all or nothing, kind of going straight into 4 shakes a day for 12 weeks. But actually then the difficulty of doing it remotely and digitally afterwards is that without significant behavioural change, it's easy to slip back into old habits. And some of that, while it's welcome, is on an app, and if you don't look at the app, then people aren't going to be chasing you to make sure that you do it. So I guess what more could we do? And what kind of tools would the government have to be able to support more people to stick with the programme longer than just the total diet replacement phase and stick with it for the whole year?
There is... Sorry, where did you want to go? I was going to go about the rescue package.
Where was it?
Yes. Well, the programme is commissioned, as you know, and increasing the number of visits during that critical phase of food reintroduction would be one approach that would increase the cost of the programme. Now, I would add that all the funded places on the programme are filled. So even though, yes, only 55,000, but it's what's been funded. The other thing that can be done is to provide more written resource to the companies that are actually providing this. Originally, in the first 2 waves of commissioning, I spoke to the company representatives who were going to pass on the education to their operatives. That could be increased. So yes, this is a process that could be improved and should be improved, but there would be some cost implications.
I was just going to pick up, there is a rescue package offered to people, so if they find it difficult and then find that they're not able to sustain it, they can ask for support in a sort of reboot. So this will, if they've spent some time in going back to sort of normal foods, they can then ask to go back on the total diet replacement, and that really helps people. We also know that peer support helps people, and not everybody gets that offer. And I think the other one is recognising that people's lives are complicated, and that may not be the right moment for them, but any weight they have lost has given them health benefits, and perhaps they then come back to it in several years' time. I think one of the real issues around weight loss is this sense of success failure being totally binary.
This is absolutely a theme we've heard over and over again, believe me. Yep.
I won't say any more then.
And so, I mean, coming on to kind of the experience, and it's great to hear that you've been working directly with people, as I would expect, and you do a very good job of it. Why do you think, so we've heard evidence that basically this programme is much more positive, people are much more positive about it than, say, GLP-1s or bariatric surgery. Why do you think that is, and what lessons could we learn for other kind of methods of weight loss that could apply?
I think it's the delight of discovering that they have control. they're in the driving seat and they start feeling better, I'm sure you did, within a week or two. Just getting up out of a chair, lifting, the average weight loss in the first week is about 4 kilograms. So lifting over the course of 2 weeks, that would be at least 6 kilograms every time you stand up. That makes a huge difference. So it is auto-motivating in a way that they can feel they're in control. And being in control is what we try and achieve in medicine, but it's so rarely achieved. But this is a prime example. So I think those are the reasons why this is genuinely a well-received programme. I have to point out that it's people who are motivated to do this who've joined the programme. And so that has to be acknowledged. It's not for everybody. Not everybody has the time, the family support, the freedom from other worries of the moment to be able to embark upon it. So yes, it is a selected bunch, but I'm pleased they're happy.
I think there's another reason, and that's because people can lose medications. So they are being told that you're going to go on medication for your type 2 diabetes, but this is a route where you may not have to. And I think you've probably heard a lot about the stigma and shame that comes with having type 2 diabetes and with having overweight. This gives some route to process some of that.
Could I just add that I get a large number of emails from people with diabetes in relation to this, but one common recurring theme is a complaint about having been to the GP, diagnosed with diabetes, and they emerge with a prescription for metformin. No explanation, no mention of this programme. That is so common. Now, that could be tackled. The matter of asking the various GP organisations to increase awareness and point out that this is not satisfactory. The second point is the perverse incentive from NICE, because one of the quality standards in diabetes is the number on SGLT2 inhibitor agents. Now, this is crazy to have a standard for that, but not a standard for provision of weight loss advice. So there are some substantial problems around this, but the bottom line is people do not like taking tablets.
No, I mean, my experience of it, and I'm sorry to keep coming back, but as a service user myself, it's helpful context. I found out that I had type 2 diabetes through the NHS app. I saw my results, nobody had contacted me first. And then when I went to my meeting, there was a push to try and get me on the jabs. No information about this program at all. And then I say a prescription for metformin. When I got to the end of my prescription, my first month, my 28 days, nobody contacted me again to say whether I needed to continue taking it, whether I could stop taking it, whether I should continue with that on the program. There was just no contact at all. And in fact, I moved GPs about 18 months after, but I didn't. I never got a kind of a follow-up appointment with my GP throughout the program, which is, when we are dealing with young people, I say where there's a stigma attached. I've been very open about my diabetes. I think I'm trying to be helpful with that and use my position here to talk about it as a young person with type 2 diabetes. But when you have that stigma, when you're worried about it, that really does have a major impact. What could we do to that stigma and to encourage young people? I mean, I'm not ashamed to admit, it was my wife who booked my GP appointment. She insisted, could tell I wasn't very well, and she insisted that I went to see a GP. Otherwise, I would have carried on and tried to keep calm. But how do we stop young men like me from kind of trying just to brave it out and actually go to the GP when they're concerned?
Maybe I could comment on that. The recent work we've been able to do demonstrating that type 2 diabetes has nothing to do with BMI. Obesity and type 2 diabetes are completely separate areas. Type 2 diabetes occurs when a person is too heavy for their own constitution, genetically determined. We're all polygenic individuals and we all have our tendencies, susceptibilities. And if people of normal BMI but have type 2 diabetes lose the weight, we've shown the diabetes goes away. Now, this concept of the personal fat threshold is nothing to do with obesity. Coming down from a BMI of 45 to 42, metabolically healthy, wonderful. That's the diabetes bit sorted. We can get on top of the stigma to some extent And one reason Diabetes UK was pleased to hear about the proof of the personal fat threshold concept was the business of tackling stigma. So we can push more widely that type 2 diabetes is not a disease of obesity, which distresses me to hear it repeated so many times. Only 50% of people at diagnosis have a body mass index above 30. Most of the rest are overweight. 1 in 6 are normal. Now, this is Caucasian ethnicity. It's far, far greater in people of other ethnicities. So we need to get across a very seminal message there, and I'm sure that could be amplified. Now, this is relatively new research, last few years. It takes a long time to break through with new ideas in medicine. But I think the anti-stigma effect of the personal fat threshold, I think, will be potent.
Yeah, I think from our side, I think both obesity and type 2 diabetes, there are so many complex factors that cause them. And this sort of pervasive belief that it's an individual's fault. I think the more we look into the genetics, I've seen some of our Future Health's data on this, and they can look between somebody who's at low risk of having overweight and obesity and somebody who's high risk. And in order for the high-risk person to come down and reduce their risk, they'd have to do an extra 10 to 12,000 steps a day, which very clearly says, on a similar calorific intake, somebody who's got high risk because of their genetics or whatever has to do more. I think the other one is we have to tackle the food environment as well.
Which was the first half of this inquiry.
But just to loop it back, there is something about not internalising it.
Thank you.
I'll hand back at that point, and I might come back.
Oh, thank you very much. Absolutely. Andrew George, please.
Okay, so we've heard about the weight loss. What about the, or rather, what do we know about the weight gain following the completion of the programme, and how this compares with other treatments? I mean, Alex has referred to those who remain in remission after a certain period of time. I mean, it's from 2018 to 2023. I mean, do we know a great deal more now about the weight gain considerations?
We know that there is a threshold which people can bounce around and have diabetes, get rid of diabetes, have diabetes. But the seminal facts of the remission remain the same. Around the 10% weight loss, 8 to 10%, people can be in remission. If they go below 8%, most will revert to having diabetes. But I would emphasise that at 5 years, there's still 6.1 kilograms average weight loss compared to baseline. That's a huge effect of the programme. That will have implications for all sorts of aspects of health that we haven't touched on. Cancer rates are going to be lower, ischemic heart disease, stroke, lots. Sleep apnea will be much better, for instance.
But I mean, how does this compare with other treatments? I mean, is the weight gain more significant in following this programme or less?
Thank you. I'd start off right away by saying that looking at persistence of weight loss, that's bariatric surgery, and I'm sure there'll be very useful points made in the next session.
Yep.
But second to that, perhaps we have the GLP-1 agents. I'd point out that the headline news about these agents is a little overblown, because these first studies were always designed as marketing studies from the companies. They're not designed to inform doctors or patients. And in real life, tirzepatide will achieve about half of the advertised weight loss, unless all the points that are carefully also described in the paper are satisfied. Now, one aspect is the provision of an intensive lifestyle management along with it. So, with an intensive lifestyle management, very frequent follow-up, yes, using the drug might get 20% weight loss. If we don't have those fulfilled, it's about 10%. So, that aspect's important. But in relation to the weight regain, that's very disappointing, because people have not gone through any aspect of being trained about how much they eat. This isn't education. This isn't being talked at in a lecture theatre. This is training, like learning to use a spade. So the food reintroduction phase, with careful monitoring of weight, is a real learning point. GLP-1 treatment, by and large, haven't had that. Now, whether it could be built into the end of a programme or not, that hasn't been tested. But that clearly is an important question for the future. Without it, weight regain is essentially complete within 1.5 years by the best data.
Yeah.
And so you were saying it's too early to say what the ultimate kind of weight gain scenario is with regard to GLP treatments, because we don't know enough about those people who've come off them so far. Is that right?
We have got the data about
we've got very clear data of coming off them.
Okay.
With a very rapid weight regain.
Right.
But by and large, this has been without intensive, appropriate lifestyle guidance on what to eat to manage the new lower body weight.
Okay, but the direct study found that by 3 years ago, that only 13% of people remained in remission. I mean, is that a matter, do you think, of concern? I mean, how can we improve on that? What have you learned that might improve the outcome?
Thank you. It's not a matter of concern. Over the period of follow-up, weight loss was around 2 kilograms on average, just over 2 kilograms. But the follow-up was not intensive. This was not a study. This was real life. People were just in their own practices, being seen by the practice nurse at intervals which were not necessarily optimal. And even so, with the training they'd had, they were still lighter. Now, 6 kilograms isn't enough to have a substantial number in remission. So yes, we'd have all the other benefits I mentioned just now, but not actually freedom from diabetes.
Okay, and you mentioned earlier that the programme was largely, I think, delivered by non-clinically trained staff in terms of the training.
Correct.
And youth, I mean, that is interesting in itself. Although you said that the practice nurse would be reviewing the cases, the actual training was undertaken by non-clinically trained. And you're content that actually that is sufficient for the programme going forward?
It's more than sufficient.
Yeah.
Immediately after the first study, the Counterpoint study, which started this whole process in 2011, was published, I got demands from the public in huge volumes by email about how to do it. We put all the information on the website, and a second tsunami of emails arrived, and we analysed these and published the results. People can do this themselves, provided with the tools. It's a simple concept, although it requires determination and the necessary information. So training non-professionally qualified people to do it is entirely unremarkable. It's not safe. It's not unsafe to lose weight rapidly. It's rather unsafe to sit down to dinner. I wouldn't advise that if I were you.
So I mean, you were mentioning earlier the issue of we're all polygenic individuals in relation to the potential conflation of diabetes with obesity, but in relation to the success of this program, let's call it a success, a lot of remission, some good outcomes. Can anything be learned from that in terms of widening it to addressing wider issues of obesity?
Very much so. First of all, comparing this with obesity, it is also a condition of polygenic influences, largely upon appetite. Now, it's not well recognised that appetite is a quantity that's distributed unfairly amongst the population. Mm-hmm. Some people are blessed with great appetites, others can happily skip meals without bothering. And this range is really not recognised. We have to understand that individuals are individuals, and certainly as a doctor, I'm treating the person in front of me. Mm-hmm. And so the polygenic nature that has caused this person to be this weight in this food environment the polygenic environment is irrelevant. It's happened. And so exactly the same processes can be used And that's why I'm so pleased to see the Healthier You suite of programmes arising, because yes, this can be applied to obesity. It was actually trialled by Professor Susan Jebb in her early study, the droplet study, and it produced quite similar results to those of direct. So we know this can work in obesity. We know that it's one of the effective offerings that can be put forward. So obesity, we have the successful, effective dietary approach. We've got GLP-1s that we're still learning how to use, and we've got bariatric surgery, which for selected people is such a good option. Now, there are aspects to bariatric surgery which make it out of court for widespread use, but for its best use of individuals who really have problems, it is without peer. So we have 3 big approaches, and these can be orchestrated as necessary for the one person in front of us with no stigma.
So, sorry, yes, please.
I just wonder if I could add to that some of the underlying factors that make it work. First of all, these have all been based on the National Diabetes Prevention Programme and the Remission Programme have been based on high quality research. So there's an evidence base, in globally peer reviewed. So it's not sort of amateurly done somewhere. It has been sort of professionally the data pulled together. Then it's been done at scale. It's been done with an expert programme of clinicians and commissioners, so they've really thought this through. They then run pilots, they then gathered the data, taken the learning from that, and then they've continued doing the learning and gathering data as they've gone through rollout, which is why you then end up with something that can work at scale and is actually rigorous and robust and take the learning and get better, rather than a lot of weight management services which are offered in a very local way, fairly ad hoc design. And the other thing behind these, they're funded. You know, some sensible money is being spent on this in order to achieve results. It's cost effective and lower cost than doing it in an ad hoc way, but it is being sensibly funded.
I just want to properly understand the interrelationship between obesity and type 2 diabetes. I mean, I know certainly there are cases where people are certainly far from obese but have type 2 diabetes, and clearly the kind of program that you're describing will have less relevance to them. Is that reasonable to say?
No, it would have exactly the same relevance, but at the present time the programme is aimed at people of BMI 27 to 27 and above. That is because of the evidence base. Now, I had trouble smuddling the first study through the ethics committee. The idea of losing weight makes people nervous, or made people nervous, it should no longer. And that's where the figure of 27 comes from. Right. Because we'd already done it once, it's stuck with all our studies, including direct. It's now emerged in the national programme, and I can't budget despite requests. It has to be said that people BMI under 27 tend to have less trouble losing weight upon advice. Right. And it's very striking that at 1 year after the Retune study, which was my study of normal weight people, these people had not put on any weight at all. Oh. Whereas in the obese category, with rather greater follow-up, they had put on about 4.5 kilograms. Yeah. So, yes, it can be used, but we're talking about cost effectiveness here. And it requires a cost-effective approach to decide whether to move down into these lower ranges, which would be very popular with people in that range. It would certainly advantage ethnic minorities because there's a gross underestimation of the difference in BMI for metabolic benefit. It's at least 3 and probably more. So there would be an advantage in moving the limit down, but economic factors and practicalities are to be considered.
And so, I mean, the other side of the coin is what proportion of, say, people over 40 who are clinically obese are likely to have type 2 diabetes, or is that simply a prejudice?
There will certainly be a higher proportion who, well, as I say, overall, 50% of people are obese at the time of diagnosis of diabetes.
Yeah.
That, I don't actually know the figure for younger people, but it's probably about the same,
Right.
but with a more rapid time course.
If you're rolling this, if you're advising the program, the government to, in terms of rolling the pathway to remission program out further and scaling up, I mean, what would your advice be in terms of the design of the program itself?
We would want to make sure that the food reintroduction phase was adequately resourced. We would want to make sure that the information given at the outset, especially the thinking in advance and the involvement of family and others, was fulfilled. And we would want to fund more places, because at the moment there's no problem in filling the funded places. But it is necessary to somehow get the message out to general practice. The overall general practice bodies do need to act on this. They've been very silent on this. And I'm afraid there's a feeling that low carbohydrate diets are the way forward, despite all the evidence. Low carbohydrate eating is very reasonable, but it just doesn't cut it. And unfortunately, that's been the drive of various general practice bodies, apart from the Primary Care Diabetes and Obesity Society, who have a specific interest in this and are very positive. I would add that I've recently devised a toolkit for general practice, so all the information, all the how to do it, the phrases to use in describing this process are online available for doctors, and that is sponsored by the Primary Care Diabetes Society, and that's available online as of about 2 months ago.
Okay.
Could I just add something to that?
Yes, please. Yes.
Yeah, I think people who've been through the remission programme say to us it would be really helpful to have support beyond that year. Indeed, we're trialling peer support groups in Northern Ireland at the moment who then support people who've been through the programme and then form a sort of supportive group afterwards. Because at the moment you get to the 12 months and then you are left to some extent on your own, and that can be quite tough. So that coming back and checking in on people would be very useful.
Right, and in terms of the future of the program itself, I mean, do you have a view on how many patients should be reached? I mean, are we talking about the whole population of type 2 diabetics? I mean, the evidence which we have suggests that would produce a saving of in excess of $1 billion in terms of the impact that it would have. I would have thought
the AMRC number, wasn't it? AMRC and the Wellcome Foundation did a number. They did a number based on the total cohort without the exclusions to it. So that would have been 613,000 people. Right. We think that's an overestimation. Okay. It's a smaller cohort. We've never seen, I don't know that anybody's actually calculated the cohort who could potentially be getting it. We also know from the research that after 6 years from diagnosis, then you are much less likely to go into remission. And that goes back to the earlier question about finding people early, because this is why early diagnosis of type 2 becomes even more urgent, because if somebody has actually been undiagnosed for 6 years, that potentially explains, although not evidenced, I don't think, Roy, but it potentially explains why people then struggle to go in remission, because they've actually had the condition for longer than anybody knows.
That's true. It's a matter of some people's insulin-producing cells go downhill, and if they've been exposed too long, they just cannot recover. That does take quite a long time. It's very varied. Some people can achieve this in a few years. I've had people of 23 years duration going into remission. So it's a very patchy thing. It's individual. But in terms of launching cost-effective global programs, that has to be factored in very carefully.
Okay. And 6 years is like a notional tipping point.
Yeah.
6 years is very, very rough. That figure was devised from our second big study, the counterbalance study. But it is only a rough estimate. We showed that most people in the first 6 years would go into remission with sufficient weight loss. It was about 50% by 10 years and much, much less after that. Now, this is entirely open, but in terms of acting on the evidence, that is why we're left with this 6-year limit. I would say that even if people don't achieve remission, losing weight with type 2 diabetes will take people off insulin, they'll dramatically change their risk of heart disease. And I can tell you from our counterbalance study, this second study, that the 10-year risk of heart disease was 22%, over 22, nearly 23 at baseline, and went down to 15%. So it still raised, but went down. The group that actually went into remission, shorter duration of course, went from a bit less, because they were a less complicated group, about 18, down to completely normal. They had normalised their risk, and we now know we have hard outcome data on cardiovascular disease. So the answer to your question is big improvements in health related to the weight loss alone. So we can set aside the interesting matter of remission and enjoying the freedom from this condition, separate from the need to go for health, which of course is what we're all about.
Yeah. And so to scale up, I mean, I would have thought that at least the concept of scaling up is something which I would have thought any government minister would be persuaded to do. But how can that be done? I mean, is there sufficient capacity within the system to be able to scale up to the level that we're really talking about having a big impact on the whole population that could benefit from this? And what else would need to be done if the capacity isn't there?
I think one of the very clever things about the programme that Roy Taylor devised is that it doesn't require healthcare professionals. So therefore, the whole design of it was to make it easy for primary care to be able to use. So healthcare professionals have to refer in. They will then carry on, they will give checkups to the individual to make sure that their medications are correct as they go through the remission programme, but they're not actively then involved in the actual programme itself. That is done by the external provider.
Do you think that the government's proposal for neighbourhood health hubs is the right kind of, if you like, focus on which to build such a programme? Is that something which would aid or disable such a delivery? As long
as there's a very helpful marriage between doing things centrally and doing things locally. So as long as you keep that England-wide commissioning and the data, and you don't then decide that every neighbourhood is going to design their own programme, I think at that point you get chaos and you just end up with random quality. As long as you end up with the centralised data, rigour, etc., and the commissioning, and then you have potentially obesity leads in each neighbourhood, we would see in each neighbourhood hub, making sure that primary care is then referring in, and the funding behind it to offer the places for the programme, then that could work very well indeed.
And is there a good network of, if you like, peer support across the country, as it were? So learning from good practice as well as learning where things haven't gone so well.
Yes, I think it's fair to say that could easily be done. So the hub system potentially could sort and direct properly. And for people needing this full-blown 15-kilogram weight loss program, that could be devised by provided by the commercial companies, and they will grow to take up this space, I have no doubt.
Well, the providers already do that, Piers. There is already research done to look at relative performance across providers in different locations, find out what's working and what's not working. And again, that's the benefit of that marriage between central and local. So local choice. Can I?
I've just got a few, hopefully quite short factual questions. Then Alex has got some follow-up too. Just so on future commissioning arrangements, are you at all aware what's going to happen? Because at the moment it's commissioned by NHSE. As we know, we are about to have the second reading of the bill that abolishes NHS England. Are you aware of what discussions are being had about what exactly is happening next with the commissioning? Is it going to be ICB commissioning, and so we need a clear direction from the top that everyone must do this? I mean, what are your thoughts?
What's happening?
I was just going to say the commissioning for Healthier You is actually underway, commissioned by NHS England in its present form. It would be...
That's the now. My question is about the what next.
Right.
That's
The
our
simple
concern.
answer is we don't know, but it
know.
would be disastrous for it to go elsewhere.
But what's exciting about what's happening now is they're bringing everything under the Healthier You brand, which will make it much easier again for people to find the pathway within local levels. They're also bringing in a pilot, again evidence-based. Professor Jonathan Valabji and others have sort of put this together, and he again was behind the National Diabetes Prevention Programme, and that is looking at taking the National Diabetes Prevention Programme and applying it to people probably with hypertension as a proper scaled trial to see if that intervention around weight management also leads to better results around blood pressure, etc. So there then ends up being a package which is going to be the wraparound support for GLP-1s, the remission programme, the diabetes prevention programme, and this new pilot. So that is secured, as you say, for the moment. Our big concern is, will there be a diabetes programme or a diabetes clinical lead, for instance, in a year's time? So, yeah,
thank you.
Big concerns.
Then just a couple of questions about reach. So you already mentioned Black and minority ethnic communities have a different, and I'd never heard the term personalised, what was it?
Personal fat threshold.
Threshold. And I will go in, look at this, it's really interesting. But we do know, it's well documented that for Black and minority ethnic populations, they're at much greater risk. But at the moment for the study, for the access to the programme right now, what proportion of those populations are being reached? And my question again for also socioeconomic backgrounds, because again, as we know, one of the causal links is socioeconomic background and obesity and overweight. I assume it's the same for diabetes. Roy?
So for the Path to Remission programme, only 64% were of white European ethnicity. So it was quite well represented for Black and Asian minorities. Both in direct and in the remission programme, they did quite well with the weight loss, but Asians tended to lose less weight but got similar remissions. People of Black ethnicity lost considerably less weight and got considerably less remissions. There is work to be done on just why that is so, but they were well represented. With regard to low socioeconomic class, 26% in Path to Remission were of low economic, in direct were the lowest socioeconomic
first
band.
decile.
Sorry?
Bottom 10%, is that what you mean? What do you mean by low?
The lowest, let me see, I think it was the lowest quintile. Yes, the lowest quintile.
20%, thanks.
So 26% of the lowest quintile,
Yep.
which means they were well represented.
Yep.
They actually did surprisingly well with the weight loss. The difficulty was in maintaining the weight. And that is understandable, just imagining the day-to-day life of living conditions for those people. So, yes, they are included, but we need to work especially upon the question of the poor weight loss, maybe health beliefs prevalent in the Black ethnic community. That's a question that's open. The Asian community seem to accept this quite well and also seem to do quite well. They need to lose less weight, but they get the same remissions.
Thank you
In
very much.
practice, the data is a little different. So in practice, Black African Caribbean communities and men are more likely to do the programme, but still underrepresented versus either females or the white population. So better than other programmes, but not to the representative level they should be in the population.
Thank you, that's very helpful. Alex McIntyre, to round us off.
Thank you. What's the cost roughly of a person going through the remission programme?
It's about £1,000.
£1,000.
Yes.
And just for the committee, do we know roughly what's a month on your GLP-1 inhibitor of choice?
About twice that.
So
It's about half the cost of GLP-1s, and then the National Diabetes Programme is less than that again.
so it's cost. I mean, it's a very cost-effective way of tackling.
Highly cost effective, and also for the individuals, because the saving on food is calculated at
Yeah, good point.
£640 per person. During the weight loss period, and about £1,000 if alcohol is included as a factor in the 12 months. So from the individual's point of view, this works well with people from lower socioeconomic classes. They're gaining health and spending less. Yes, it is a problem with assessing these figures. The formal economics people tend to be terribly resistant to including things that seem beyond or obvious, such as the reduction in cancers we demonstrated in the 5-year follow-up of Direct.
And I guess so from £1,000 per person investment in their health now, savings to the NHS in the long term are significantly greater.
It was calculated from the 5-year Direct data from the economic analysis by the professionals being £1,300 per person savings overall lifetime.
And finally, just before we finish, exercise we haven't touched upon yet, but it's obviously part of the behavioural kind of support changes that they try and encourage during the programme. Quite difficult to actually take on. And I guess I appreciate the diet and food as the main focus, but in terms of that behavioural support and making those positive changes going forward, what role does exercise play, and how could we, is there a role for, say, social prescription of exercise to be able to encourage more people to be active? Not during the total diet replacement phase, because I'm conscious of that's advised that you don't exercise heavily during that period, but towards the end of the programme when you're fully reintroduced to a normal diet.
Yes, it's really important to emphasise that exercise is not an option for weight loss in people who are no longer young and have put on weight. It does not work. How many friends have said they've joined a gym, sweated for 3 months and the weight's gone up? Well, I came across this in some of our exercise studies when we always have people back for feedback after a study. I learned from them what it was like and tell them the results. But one lady explained to me, well, you shouldn't be surprised there was no drop in weight. When you're coming back from that exercise session, you've only got one thought in your mind: you deserve that pie. And that caused me to go to the literature. This matter of compensatory eating on starting exercise in overweight people is well described, but it's probably the biggest kept secret in the whole of the obesity field. The reason for asking people not to start a new exercise program was to achieve the weight loss. We're entirely goal-directed on the weight loss. Now, once the weight loss is achieved, yes, we encourage the uptake of exercise. Sadly, people who tend to get type 2 diabetes do not like exercise. There may be very good metabolic reasons for this. Some of our muscle studies can give a clue to that. But for instance, despite our well-meaning exercise in Direct and people reporting they were doing more, using objective accelerometers, they did absolutely no more exercise when they were 15 kilograms lighter. So there are some issues around this. It doesn't help us. It doesn't hold us back from handing out the advice.
It's part of the challenge, though, that, say, for example, on the programme, they might refer you to a free resource like Couch to 5K. Now, anyone who's going through a running programme, some people hate it, but actually to get people active, and that's the part of a healthy lifestyle more broadly, being active is important. Is there not a role that we could play as a government to be more proactive in encouraging people to take up sports, for example? Because actually, what people, if they're not into running, they might be into tennis or they might be into paddle, whatever the new thing is nowadays. How is there a role for that as part of the programme?
There's a huge role for this in the way of preventing this upswing of gain in weight. Sadly, the biggest decade in which the upswing happens is in the 20s, in 20 and 30. And although weight gain between the age of 20 and 50 is about 25 kilograms, but it's disproportionately great from 20 to 30. These people are capable of this. Certainly, exercise plays a huge role in prevention and in keeping weight off once it's been lost, if possible. But it's always the art of the possible. It's specifically recognising that to lose weight, you need to adjust the food. For health in the long term, you need the exercise.
Or 1 million steps over the summer.
Indeed. Thank you very much.
Yes, right. Yes.
Well, thank you so much. That brings us to the end of panel one. I just want to say an enormous thank you to both of you for your time. You're incredibly welcome to stay. We're going to be discussing bariatric surgeries next. Thank you very much for your time.
Very much.
May I ask panel two to come up and we'll get started. Thank you. More than enough. I'm all right. Both. Please do pour yourselves a glass of water before we begin. And
I think Tara will be up close to his. Thank you.
we'll start as soon as you're ready.
Collaboration between clinicians.
Absolutely.
Yeah.
Well, why don't we start by introductions? If I may ask, Dimitri, would you please introduce yourselves and what do you do?
I'm Dimitri Pournaras. I'm a full-time NHS consultant surgeon delivering elective upper joint bariatric surgery care. I also do emergency surgery on call, including major trauma. And I am working at North Bristol NHS Trust. Also have an honorary position at the University of Bristol. All of my research has been in obesity, and particularly in GLP-1 hormones, which was an obscure molecule 20 years ago. My PhD. Not anymore. And I'm also the research lead for the British Obesity and Metabolic Specialist Society, formerly Surgical Society.
Lovely, thank you very much. And Dr. Neil O'Brien?
Oh yes, I'm Dr. Neil O'Brien. I'm the Chief Medical Officer for the Integrated Care Board in the North East and North Cumbria, and I'm also a GP in County Durham.
Lovely. Well, thank you very much. So we had a expert by experience interviewing panellists in Alex McIntyre and diabetes. I'm that person for this one. So I, 20 years ago, had a sleeve gastrectomy, lost half my body weight. It's the best thing I ever did. But very much interested in access to this because it has worked for me, and we know very well it's a very good thing to do if you can get it. And that's where I'm going to start. First question is, in the suite of things that we can offer people with overweight and obesity, where does bariatric surgery sit in your eyes, ideally? Maybe start with you.
Absolutely. So I should declare my view, if you like, that I treat obesity all the way from primary care referrals that I get, lifestyle interventions, pharmacotherapy, endoscopic treatment and devices, and bariatric surgery, and even the revisional bariatric surgery. And I also see obesity outside the obesity clinic in my daily clinical practice as a GI surgeon. So for every condition that we have, and I think it's really important, first we destigmatize the condition. I think it's really, and thank you for sharing your experience. It's really important to understand that people who live with obesity just live with a disease. It is a disease, and I know you've debated this before in those. It's absolutely
your view, we should say disease.
It is a disease.
Disease.
Absolutely it's a disease.
Condition. Disease.
No, it is a disease. Absolutely it is. And we need to treat it as such. And whichever definition you use for the definition of disease, you'll see that obesity meets it. Mm-hmm. I think the historians of the future will look at the way we're treating obesity in 2026 and they'll be appalled, just like we are shocked when we see how diseases were treated 50 or 100 years ago. Mm-hmm. It's absolutely a disease, and for every disease that we treat, and I'll always use examples of other diseases or conditions, like cancer, we want to do the least amount of treatment, the least invasive treatment, and dare I say pathway to remission inspired by my colleagues who spoke about this before. We have a long history. Amazing for the people that have a successful outcome. Wonderful to see that. People who do not respond to that, they just do not respond to the treatment. And I would argue, just like people with hypertension, if they do not respond to the tablet, we don't think they've done something wrong. We don't tell them to try harder. We don't tell them that they need to be more motivated. We just change the tablet. If we give people chemotherapy that doesn't work, the first thing we do is we stop the chemotherapy. In obesity, we tell people to go back and have exactly the same treatment, but try harder. Therefore, escalation of treatment is absolutely essential. And of course, the escalation stops at the most invasive treatment, that is bariatric surgery. That's where it is at the moment. The vast majority of people in this country who live with obesity cannot access it. Yep. I think it's important to take a bit of a global view, if you like, and dare I say that the prevalence of bariatric surgery in this country is the lowest in G20. It's one of the lowest in high income.
It's 117 surgeries per million in the population in England compared to 928 per million in Belgium and 761 in Sweden.
I'll trust your figures. You can look at the figures. We do 4,500 operations in the NHS. The private bariatric procedures, and we now have national registries. We had it for 15 years now. Amazing data on that. We do know that there is a number of operations performed privately, which has come down, but it's less than the 4,500. And we do know that a large number of citizens of this country go to access bariatric surgery in another country. Yeah. And I cannot think of another condition, or another disease actually to be precise, that is treated outside the NHS, that people go outside cosmetics treatments and dentistry. I don't see anyone going to other countries outside the European Union, for that matter, to access care. It's really problematic, it's really challenging. We need to do better than that.
Isn't that the issue, that people consider weight loss cosmetic?
Well, that is part of the issue, and I don't think it's people, it's the we all do. So we all part of this. So weight loss is considered a cosmetic treatment in the society that we live. We need to challenge that, both as policymakers and as clinicians and as commissioners. We do know that that's not true. We do know that the cosmetic outcomes of bariatric surgery are actually poor. The health-saving, the health-improving outcomes are excellent. The safety outcomes are excellent. The cosmetic outcomes are not something that I would consider the positives of bariatric surgery. But more importantly, the reason people go abroad is because they cannot access that care. It's not just because they see it as cosmetic, it's because they cannot access it in their country.
What is different in those countries?
The access to bariatric surgery is a lot better.
But what exactly about it is better? Just the thresholds to get it, the knowledge about it, what about it is better in those countries?
All of it is a whole system approach. So right now we know that there are parts of the country, and you have data on that have no access to bariatric surgery whatsoever. The postcode lottery in bariatric surgery is an embarrassment to the NHS, and I say this as a frontline clinician. Mm-hmm. On top of that, we have services that are shut. So who is going to refer? And I know I'm sitting next to a GP colleague. Why would you refer to a service that is shut? When you hear that the waiting time is 2.5 years and 2 years, why would you refer to that? And we also need to recognise that the tiered approach, which is again a UK unique approach to obesity care, I spend enough time in international conferences to tell you that there is no tiered approach anywhere else. It was a gatekeeping process. It's not working. It's failed. And not having access to tier service means that if you don't have tier 2 or tier 3, you can't get to tier 4. Yeah. And that is, again, a system approach, not an individual approach of a specific locality or a specific service.
Thank you. So, how do you guys do it? So Cumbria is the place where, per population, you have well exceed by more than double, I think, anywhere else in the country. So presumably they could do it too, right? What are you doing differently?
Well, we've a long history of very forward-looking bariatric units across the northeast and North Cumbria. There are 5 bariatric units, and they all work very well together in a networked approach, but they also work with the 4 specialist weight management clinics that we have. So there's a real network and partnership of both medical specialists and surgical specialists working together to give an individualised approach to what is the best treatment for the individual with obesity. That, coupled with a strategic commissioning plan, we've commissioned the activity that is being done. We commission 900 bariatric procedures per year, but that's still probably not enough for the demand that's out there, and we commission 4,000 slots for specialist weight management clinics. Again, that's probably not enough, particularly with the advent of the new medications that have come. So last year we chose to invest another £1 million into specialist weight management clinics to try and improve access for some of those underserved communities. So I think we've had we've got a good group of clinicians who work together with commissioners to really try and improve the access to this very high-end specialist end of the obesity pathway.
Thank you. So we heard in the last panel, and it's been a theme particularly of our lived experience roundtable, about how stigma is in of itself, particularly stigma internalised by GPs and commissioners, one of the reasons why this is harder to do than other diseases or conditions. Is that something that in Cumbria you saw and faced head on, or what was different about Cumbria, or does it still exist? Do you recognise that characterisation?
I do recognise the characterisation. I think stigma is, there is a lot of stigma around obesity, but again, remember, we haven't provided access to everybody who could benefit from this treatment, and there is still some variation in our patch. The northeastern North Cumbria is quite a large geography, so there is some variation in access. So, for instance, in Sunderland, that's probably where one of our most active bariatric hubs is, and then that's where the highest number of bariatric surgeries actually do happen in absolute numbers rather than per thousand. That also happens to be the area which has the greatest proportion of morbid obesity.
Right.
So we've tried to work with the clinicians across primary and secondary care, and the secondary care clinicians do reach out to GPs and try and educate them around routes to access to bariatric surgery.
You said the word happens. So was it happenstance that it was in the right place, or was it that, you know, here is an area of relative deprivation of large number of health conditions, we're going to put a hub there? Was it happenstance, or was it actually something that grew over time
It
of a population that needed it?
Yes, it absolutely grew over time to serve a population, but the numbers that are done in Sunderland, say for instance my patients in County Durham, I would refer some of those to Sunderland. They're not all Sunderland residents, but the largest number of bariatric procedures do occur in the Sunderland Trust, because they've developed an area of specialty in that over the last 10 years.
What I'm trying to get at here is, what can people learn from you?
Could I come to that, if that's okay? First of all, I may change my trade ticket and go to the northeast, and that's amazing what's happening there, and I know the history, and that's fantastic. But it also shows that there are services that exist there, and you capitalise on the fact that there is infrastructure. The challenge, and I've been in this before long enough to tell you that there are very few new centres, new units, parts of the country. So the Northeast was really good a few years ago, it's amazing now. But in parts of the country where there's no bariatric surgery, and I can show you some of those maps.
We have a map.
East Anglia, bariatric surgery deserts, they haven't changed. The needle hasn't moved for the last 15 years. And that is the challenge. The very few new bariatric units established in the last decade. Although the disease of obesity is changing epidemiologically, we have not responded to that.
And that brings me to my next question. I mean, there's calls for us to double the number of people receiving bariatric surgery. What would it take to achieve that?
We can do that tomorrow.
Oh, really?
I can give you the back of the envelope calculation. So there are 150 bariatric surgeons in this country. Not all of them are in the northeast. Around the country, 150. 160 that they contribute to the National Bariatric Surgery Registry. So if those surgeons work 40 weeks a year, you take annual leave, study leave, time to come to the Parliament to give evidence, and you ask everyone to do 3 operations a day, which is well within. In Bristol, we do 3 by lunchtime. So if we do 3 operations a day, really conservative, that's 20,000 operations with current infrastructure. No new investment in terms of training. Of course we need more training, of course we need more infrastructure, but with the current bariatric surgeons that we have in this country, if we ask them to do what we are supposed to do, bariatric surgery, and perhaps we may have to deprioritise, and I'm pretty sure that's challenging, some other treatments that I provide, perhaps gallstones or hernia surgery. If we prioritise that is highly doable. If we move to 20,000, that is 4 times more than what we do now, but it's also getting closer to where we need to be. There's about 3.2 million people who qualify for bariatric surgery. We don't need 3.2 million operations. We can't deliver that. We can't even deliver that in pathway to remission. But we can do a lot better than 4,500 operations.
Thank you. Do you have anything to say about that?
Again, I've asked that question in the northeast North Cumbria. Could we double our capacity? And if we had the right amount of theatre time and investment, then yes, the workforce is there and the demand is also there. The waiting time to access bariatric surgery, even with the amount that we commission, is in excess of a year in the northeast and North Cumbria. So we could, with the right amount of prioritisation and commissioning of it.
Thank you. So I mean, I'm drawing an inference, but tell me if I'm wrong. So you spoke about the tiered system being unique to the UK. I mean, I don't think I'd fully appreciated that, that it was totally unique. And there's calls for a hub model, that you sort of refer in, treat the patient in front of you. Would you advocate for a model like that to counter the fragmentation, or do you have a different view about what needs to happen next with surgeries and treatments for obesity more generally? Do you have?
I'll start by saying that the treatment for every disease that is complex, and obesity is complex, is multimodal treatment. With the different modalities, and obesity is unique in the sense that we're talking. So if I just change my vocabulary and I used cancer here, we wouldn't be having discussions if we should have chemotherapy first or radiotherapy first, or let's just try immunotherapy only, but let's not invest in cancer surgery or robotic surgery. So we need everything, for not at the same time, of course, but for different individuals at different times. So, of course, we'll have a stepwise approach to any clinical care. We do this for every other treatment that we provide, and obesity is the same. But people don't need to do time. People don't need to do 6 months of so-called Tier 3 service. It's now been removed from the NICE guidance as specialist weight management. We just need to see if they can respond to that treatment. So if people respond to the pathway to remission, that is fantastic news, and we just need to continue doing that. For the people who did not respond to the pathway to remission or did not respond to GLP-1 receptor agonists, we need to escalate treatment and offer bariatric surgery. This needs to be seamless, and I think that primary care are really well placed to know how to do that, and we can work together to deliver that model of care, just like we do for every other condition.
I would agree. The removal of the barrier where you had to serve your time in Tier 3 has been helpful. I think integrating all of the options for treatment for obesity under the specialist weight management clinics, and it may be that an individual's access to bariatric surgery should happen sooner than would have maybe happened before. This is becoming a much more technical area for GPs to understand and to know where to refer, again, which is one of the big benefits, I think, of the structured weight management programs, which have got a multi-professional skilled clinical workforce in there who can decide the options that are best. So I think that it's the integration, removal of the tiering. But that being said, we still need to make sure that local authorities who currently commission what is Tier 2, which is the behavioural side and the dietary advice, exercise advice, that still needs to be there as a bedrock so that to allow and improve the success of some of these more technical high-end treatments.
If I could come up with that, I also think it's important to recognise the gap in care. And that is demonstrated by the daily news of a lot of people accessing pharmacotherapy for obesity privately. That there's a gap in care there because they cannot access it via the NHS, they cannot access it via primary care to an adequate level. And the levels of the disease are reflected by the level of people who access those treatments, not by the levels of commissioning we do or care we provide. Therefore, we need to recognise that gap in care and do something about it.
Thank you. I have one final question and then I'll move on. We've heard consistently how some GPs get it and speak about obesity in a way that the patient will be grateful for, and then there are others who maybe don't know about the services they can refer into. I was quite shocked by, Alex, your story earlier about you finding out about diabetes by the app and not by your GP. I thought that was astounding. What more do we need to help GPs to be able to navigate this complex system that you've described, but also do it in a way that is compassionate to the patient in front of them? Neil, can I ask you?
General practice is probably one of the best jobs in the world, but is becoming one of the most complex jobs in the world. Yeah. I'm fortunate I'm in a practice where I have many partners and we all have various different interests. So I think the variation in experience that people may have had will reflect maybe some of the interests that GPs have. That being said, certainly for I applaud the Healthier You. That has certainly raised my awareness of the diabetes prevention programme, but it's very difficult to keep pace with all the changes that are happening in this field, and the view that obesity is a disease is a relatively new concept for us in medicine to get our heads round. And so not only are we looking at an individual to manage their cholesterol, their blood pressure, their smoking, we're now looking at treatments for their obesity, which I think is absolutely the right thing to do, but it will require a lot of education, I think, for GPs on both when and how to refer, but also what they can manage themselves within their practice.
Thank you.
Could I add on that, if that's okay? I just need to reassure Neil that secondary care is no better. So the education gap in secondary and tertiary care where I live is also problematic. Most of us were not educated on obesity. But we know that if there is an epidemic, we know how to respond to it. And everyone remembers the COVID-19 epidemic. And very quickly, we all became experts in virology, in microengineering, in epidemiology. Very quickly, we learned how to deal with COVID-19 in a very short period of time when we recognized that it's an important disease to treat. And even in the elective surgery space where I work, we very quickly learn how to do that. So if we decide, and because I think there is an element of choice here, if we strategically decide as society and as scientists and clinicians and policymakers that this is somewhere to invest on, it can quickly happen. I train medical students in the University of Bristol, and I've stopped actually all my training and I only deliver an obesity lecture because I think that's the most important bit of the training, because that's the part of care that may have an influence on outcomes more than anything else I can spend 45 minutes talking to them about. So we can change that.
Thank you very much. Danny Beals.
Thank you very much, Chair. You've made a really compelling case about the untapped potential of bariatric surgery. Do you, with the variation that you've spoken about nationally, why do you think commissioners locally just don't get it?
Well, it's difficult to say this in front of Neil, who clearly gets it, but the easy answer to this is stigma. Stigma is dominant not just in society, but also in every interaction we have. Within my own hospital, with my own NHS trust, within the local policymakers, obesity is not treated as a disease. If obesity was treated as a disease, all of those problems would go away.
That would be the driver, just treating it as a disease.
Absolutely.
Would all these commissioners
Absolutely.
would suddenly kind of commission more bariatric surgery?
If I only had one button to push, that's the one I would push. And we can see that by learning from other diseases. Cancer is a really complex disease to treat. And there are waiting times, and I don't envy the health policy makers, and there are difficult discussions about, which immunotherapy to use or not, but we deliver that, and we deliver that in a timely manner, and I don't see thousands of people leaving this country every year to go and get cancer treatment elsewhere. The same thing for benign conditions. I don't see people with hernias and gallbladders and hemorrhoids going elsewhere to access this treatment, but they do for obesity, and that tells us everything we need to know.
And Neil, you clearly do get it, but do you think there's too much reliance at the moment on personalities and passions and personal beliefs in bariatric surgery and interventions in this space that drive decisions and lead to variability? Or do you think there's other explanations about why lots of areas just don't do what you do?
It's very difficult as a commissioner to try and work out how best to use the finite resource that you have. It's the job of every commissioner to understand the health needs of their populations, and certainly in the northeast and North Cumbria we have quite a high prevalence of both obesity and morbid obesity, which has driven commissioning decisions over the years. That, coupled with, yes, an enthusiastic clinical workforce, some specialists in the area, a desire to develop that and improve the pathway, have led to the position where we're in now. But please don't get me wrong, we haven't got this fully sorted. There is much more that we can do, but yes, we are ahead of other areas in respect to the provision of bariatric care.
Perhaps to add on that, if that's okay, if I'm allowed.
I was just going to.
If you look at cost effectiveness, which is what usually drives commissioning, bariatric surgery is extremely cost effective. It's one of the most cost effective interventions ever assessed by NICE. and remains dominant. And if you start adding societal impact, and I've sent some of that data in terms of employment, in terms of going back to work, in terms of cost.
Case is very strong indeed.
Very strong, but it hasn't changed the access to care, which demonstrates there is something beyond data that is lacking. And I think that's why going back to the stigma is key.
So Neil, you talked about your, commissioning for local population needs. So is your view that the areas which are not commissioning at the moment, their obesity levels are such that it's less of a priority? Would the commissioning of bariatric surgery map to those issues of deprivation, of obesity, of local need?
Well, if you look at the map, it doesn't follow that exactly. There are certain areas within the country that have equally as high obesity levels that don't have the level of bariatric commissioning that we have.
Why do you think those commissioners then are not commissioning for population need?
I'm not quite sure. You would have to ask them. It may be historical arrangements that have, or they've prioritised other areas, or they might be in a different financial position.
I could provide a national picture on that, if that's okay, to answer that question. It's not a coincidence that areas of poor socioeconomic status have limited access to bariatric surgery. Getting bariatric surgery it already puts you at a high socioeconomic level, not just because of, and that's just in the NHS. You have to have the ability to communicate and make that point across that you want that care. You have to be really articulate and be patient enough to go to enough GP appointments to ask for it. In this environment, I'm not talking about at social level, not necessarily in the North East, but nationally. So the reason that people are not getting obesity care in those poor socioeconomic or those areas with poor socioeconomic status is exactly that. And there's also a racial aspect of it as well, and a language barrier on top of that. So it's multiple complexities there, but it's around exactly that socioeconomic issues that you described.
If we accept that currently local, so in 2017, bariatric surgery was devolved by NHS England to local areas, CCGs at the time, now ICBs, on the basis that they would design effective local pathways, respond to local population need, and I think they aim to increase consistency in the pathway for obesity management. It seems that hasn't happened. There isn't consistent pathways. From what we're discussing, it doesn't seem like what services are commissioned around bariatric surgery map local population need from the data we were just discussing. Do you think in this instance there's a case for more nationalised commissioning of this area or clearer national standards?
I think having clearer national standards and what the expectations of commissioners, I think that will be helpful. Yeah. I think national commissioning of this model, because it's a whole pathway and would require systems working together in the setup of specialist weight management clinics and then pathways across primary care through medical specialties and surgical specialties and aftercare. I think local commissioners are probably best placed to broker some of that, but I think some national expectations and commissioning around this would certainly help.
Do you think the progress that's been made we heard about the remission programme previously, we've heard about the diabetes prevention programme previously, kind of nationally committed to programmes pushed by NHS England with some degree of local involvement, obviously. Do you think there's a kind of case around that kind of model for bariatric surgery, as you were saying, kind of?
Yes, I think setting some very strong national expectations of what commissioners need to provide for their populations in this aspect of obesity treatment would be helpful, and local commissioners should be held to account for that.
I would completely agree with that, and I would say national policy is urgently needed. When we have such local variation, it just shows that, although I appreciate the local commissioning concerns, but if we have such a gap in care with wide local variation, national policy is urgently needed to meet that gap.
Thank you. And what? So there are some nice standards at the moment. I think some data that we've seen has suggested that around 31% of ICB areas are not following the NICE criteria in full. There's kind of variation in who can apply for bariatric surgery, which isn't compliant with NICE, and some areas with no provision at all. Obviously, NICE is already some level of kind of clinical standard. A third of areas essentially are not following it. What should accountability look like around standards and expectations about this or future standards? What, from an ICB perspective, from a provider perspective, is there enough accountability now? Should there be more accountability?
I think from an ICB, I mean, there's if you look at compliance with NICE guidance across all disease areas, you will find that despite best efforts, we can't deliver that standard of care for everybody in every population. In relation to this, again, we're certainly moving towards a more strategic approach to commissioning. So we could estimate our level of required activity within bariatrics, and we should be commissioning that level of activity. So certainly NHS England, or what comes next, could also hold local systems to account in order to ensure they are at least commissioning or are on a path to commission sufficient capacity in order to make this treatment accessible. But I would say through the structured weight management clinic approach, which would then allow access to both the new technologies in medication and GLP-1s, and then picking out the people who would really benefit from bariatric surgery.
What would that accountability look like now that you said it's possible now via NHS England, potentially in future via Department for Health and new arrangements? But so the 31% of areas who are now not compliant with NICE criteria around bariatric surgeries, what would accountability look like? What could NHS England do now?
Well, NHS England could put some very strict targets in around what they'd expect to see commissioned capacity in that area, and hold areas to account to deliver that.
Thank you for making that point. That's really important, because NICE guidance is uniquely not followed at commissioning level so regularly in bariatric surgery. So the first NICE guidance that suggested that for patients with a BMI over 50, bariatric surgery should be considered as first line was in 2002. And I have been seeing patients with a BMI over 50 coming to my clinic for other conditions. Nobody has ever even told them they have obesity. That's probably even before the NHS app. So it's about that accountability that needs to change. And that is not just commissioners. That's not the issue here. It's all of us. Healthcare providers, both at primary and secondary care and tertiary care, who should be accountable to that, to deliver this. And it goes back again to that stigma issue that we have. How is it acceptable to have commission criteria in parts of the country outside the Northeast where the BMI criteria are not meeting the NICE criteria? How is that? Imagine doing that and for chemotherapy and saying that for people who have this cancer in this area, you're not going to get the nationally approved criteria, and no implications or consequences due to that. So the accountability question is the key one, and I think we need to address that urgently.
And if we move to more nationally commissioned service, do you think there's a need to commission a service in every area, or should we be focusing on kind of super hubs to deliver this? We've heard some evidence around kind of surgical space and time and facilities are a barrier in certain areas. So would commissioning kind of specific bariatric surgery hubs nationally to commission into be?
Absolutely. I think we should have national coverage, but I don't think that every hospital should deliver bariatric surgery. It's highly specialised. The safety of bariatric surgery now, so if you look at the 30-day risk of death from bariatric surgery in the UK, it's 5 times lower than the death of a cholecystectomy, of a gallbladder removal, a routine operation. It's extremely safe because it's performed high frequency, high volume in highly specialised units. So absolutely we need, we do not need occasional bariatric surgeons. We don't need occasional bariatric units. We need, and you can do hub and spoke, you can centralise just like we did with cancer. The NHS is amazing at delivering that. Cancer care was centralised in this country 20 years ago and we're world leading. Vascular care, vascular surgery has been centralised. Major trauma surgery, major trauma care has been centralised, and we're now saving lives that we're not saving 6 years ago and 10 years ago because everyone gets flown to the same unit. We know how to do that. This is business as usual for the NHS if there is a will to deliver that. So absolutely it should be at least centralised, and the model of that can be worked out in detail with the right stakeholders.
Thank you very much. Greg Stafford.
Thank you very much. I'm going to ask questions about Tier 3 services. So currently patients are reviewed in specialist weight services, Tier 3 services, for their suitability for surgery. Do you believe this approach is working, and what impact, if any, might it be having on access to bariatric surgery?
I think the requirement to do a certain amount of time in a Tier 3 service, which is mainly around behavioural and education, the removal of that requirement, I think, has been helpful. I think speaking to specialists in the area, they would much rather see a referral to a specialist weight management clinic, which is a multidisciplinary approach to pick out those who, yes, might be on maybe a more intense behavioural modification program, or those who might benefit from medication, or picking out those individuals who probably should be fast-tracked through to bariatric surgery. I think that's a much more helpful way of managing the pathway than mandating Tier 3, because even in the northeast and North Cumbria, we did have pockets where the Tier 3 provision was actually where the big waiting time was, and people were waiting for a very long time to access Tier 3, and then that meant they could not go on to be considered for bariatric surgery. So I think moving away from this tiering and having a more patient pathway approach is probably favoured.
Add on that, if that's okay, that the history is quite important in this, and understanding why Tier 3 existed in the first place. There was genuine concern amongst clinicians, amongst commissioners, amongst policymakers that everyone's going to have bariatric surgery. Like the whole world, the whole of the UK, who has a BMI over 30, there's 3.2 million people will have surgery. And Tier 3 was seen as a gatekeeping to make sensible decisions. That's not happening anymore. Well, it never happened. What they did was delayed care. The access to Tier 3 is problematic if you have to do Tier 1 or Tier 2, but you don't have local Tier 1 or Tier 2. If you don't have access to Tier 3, a lot of Tier 3 services in this country are shut in your referrals, so you can't even access them even if they do exist. And then you have to go to Tier 4. So absolutely removing it is important. And I think the focus of specialist weight management service would be to signpost and improve access to appropriate care. So someone with a BMI of 60 who's already been to the pathway of remission and hasn't responded, they need to go to bariatric surgery sooner rather than later. Someone with a BMI of 34 who got diagnosed with type 2 diabetes last week, maybe they can try pathway to remission if their biology, the genetic profile, and the social circumstances allow them to have that. That needs to be seamless and rapid so people can re-enter when treatment doesn't work, just like we do with oncology. So if the chemotherapy doesn't work, we need to be responsive to that, as opposed to be really rigid about you need to spend your 6 months of chemotherapy now.
So are there any other specific changes that you would make to the pathway to ensure that you get to the sort of position that Dr. O'Brien was talking about?
Yes, I would ensure that access to the modalities is really, again, rapid. So, and again, we need to have a discussion about this. So people should be able to access pathway to remission or intensive lifestyle modifications early. And if they don't meet that, they need to be able to move to pharmacotherapy, GLP-1 receptor agonist-based treatment. If they do not respond to that or they cannot tolerate that, they need to be offered bariatric surgery. That needs to be responsive in real time. And if people are not able to undergo treatment for obesity right now, it is a chronic disease, it's not an injury, it's a lifelong condition, then they need to be discharged and then they can re-enter at any point when the conditions are right. And that's the change that we need to see in the landscape of how we're delivering obesity care.
Yes.
Just a supplementary to that, GPs are now starting to prescribe GLP-1s to a very limited cohort of patients, and that'll take time for GPs to become experienced in doing that. So you can start to see in time, when expertise builds, that some of the kind of less technical, if you like, interventions could be done in general practice. So I think upskilling general practice, the first line treatment could start to be done across the country if GPs are resourced to do that, and then go on to the specialist weight management clinics. That would be the only other slight adjustment to the pathway.
And just briefly, because I've got another substantive question, but is that something that you think, in your experience, GPs would welcome doing if given the resources to be able to do it?
I think if given the resources to do it, yes, because I see patients every day who I know would benefit from this medication. At the minute, I can't prescribe it for them, and the support or wraparound support isn't there, but I know they would benefit from it.
Thank you. So we had evidence from the Royal College of Physicians who raised concerns about surgery being prioritised on a first-come, first-served type basis rather than on clinical need. Is that a characterisation that you both recognise, and what could ICBs or indeed government do to address this problem?
When you have a system which is overloaded, you have long waiting lists, those discussions become less important, because if people are waiting for 2 years to access specialist weight management, does it really matter which is the first operation I do? It is clinically not correct to prioritize on waiting time, and it's because, again, we're not treating obesity as a disease.
Just so I'm clear, do you accept the Royal College of Physicians' assessment that that is what is happening?
That is what is happening, and the problem is wider than that. Is the fact that there is long waiting time. When you have an overwhelmed system, people go on the waiting time. But if I'm allowed to sort of use an example, we also do operations in people's bowels and people's colons. And the waiting time for someone who has an inflammatory condition is different from someone who has a polyp, who may turn into a cancer, is different from someone who has a cancer today. And the NHS has very clear targets on those. You all know what they are. In obesity, we don't have this because we don't treat it as a disease. And people's obesities are different. And I think you heard Professor Roy Taylor earlier on. Our ability to stage the disease is very poor. We're having debates about what is the definition. We're even having debates if it is a disease or not. I've moved beyond those. So we don't have good data to say who needs an operation first. And I can give you 2 extreme examples. A patient who needs a renal transplant, a kidney transplant, and they have to have a lower weight to achieve that, is in a different priority from someone who perhaps has a BMR 50 but is fully functional and has a full employment and reduced cardiovascular risk. We don't have great tools to do that, but I don't think that is the biggest challenge today. The biggest challenge is the waiting time as opposed to who comes there first.
I think your point as well highlights the inequity of care as well. Well-articulate individuals who are well-informed will know how to access the system. I think as part of the whole pathway for the treatment of obesity, the identification of individuals who would benefit from treatment in a systematic way, just like we do screening for other health conditions, also needs to be part of that, so we can then treat people on need.
Just briefly, both of you, who is responsible for doing that? Is it ICBs individually? Is it a national governmental change? Is it NHS England or the department, as will be? Who is responsible for getting it to the state that you're talking about there, as in a future state?
I think as strategic commissioners, we have a responsibility for our population to ensure that we have a pathway of care that allows the people of the North East and North Cumbria to access all modalities of treatment. And we've got improvements that we need to make, but I think in some areas we're strong and others we're not. But I think also, yes, but as I mentioned before, if there was a national steer on what was the expectations around that whole pathway, right the way through from identification through to what's expected for aftercare, I think that will be useful.
So if I may add on this, the quickest way to have impacts on socioeconomic imbalance in this country is to treat obesity, because it is this condition that is affecting disproportionately BME and poor socioeconomic. Access to care in that underserved group is worse than it is for the rest of the population, and by treating obesity we'll improve outcomes, we'll improve education, and there's evidence of that in the younger population and adolescents and children. We will improve outcomes, we'll improve employment. So it's really important that we see obesity through this lens, not the other way around.
We have an interesting debate about causal symptoms in there, but I will leave it there. Thank you very much.
Yeah, I went to go visit one of the Q clinics up in Sheffield, and they were making the point, whilst it's an acute service, it's also preventative in the long term, because these are children who are being treated. I want to talk a bit about aftercare, because you've mentioned it a couple of times, and it came up very, very strongly in our lived experience roundtables that we did. And I'll use myself as an easy target example, but it's not just a case of you have a surgery and then that's it for life. I have ongoing issues with anemia, whether it's B12 or iron. There's the sagging skin, which somewhat offsets the cosmetic benefits that people talk about, and I think is shared by a lot of people who lose a lot of weight rapidly. I have Barrett's esophagus, which is one of the outcomes that can happen after the surgery, which means you need to watch that for cancer down the line. I mean, it feels like it's never ending, and the surgery itself was something that I now need to watch. And, insult to injury, I've now put weight back on and I'm back on a weight loss program. What I found remarkable when I was in that room full of people in our lived experience roundtable is I suddenly felt like we were all having the same experience in different forms. It was just a matter of what we were experiencing when that changed. The thing that didn't change is that all of us, after the intervention, whatever it was, had ongoing issues that we needed dealing with at various points over the decades. And what was also equally uniting was how difficult it was to get any help for them. So my question and I'll start with Neil if I may, you mentioned aftercare. What is currently available in your patch? And could you compare that to elsewhere? Let's start there.
So we've broken down the aftercare in the immediate 2-year period after a bariatric procedure and then care beyond that. We have ensured that all of our bariatric units provide the aftercare for that first 2-year period, and that involves various kind of nutritional support, blood monitoring, that kind of thing. In addition to that, we've already mentioned about people going abroad. We did have a particular problem of people going abroad and then coming back and having no aftercare, and then sometimes ending up in emergency room departments, or sometimes just pitching up to their GP, and that was very difficult. So we've actually brokered an agreement with our bariatric units that any individual who's in that situation, they will also do their 2-year bariatric follow-up. Beyond that, it will be out to general practice, and we're currently in the process of developing what's called a local enhanced service, which is an agreement between commissioners and GPs to provide structured aftercare for patients following bariatric surgery. That's not yet in place. We're in negotiations with it. In my practice, we've got a register of people. Can I say hand on heart that we actually bring them in every year and do all of the things that need to happen with them? Probably not. But that structured annual recall, follow-up, and then route back into bariatric surgery when people start to develop any kind of complications is what I think we need to firm up.
Can you be specific? What things, so blood work, nutritional support, what about psychological support, any of that? Part of it?
I'm not sure if that's part of the hospital service or not in particular, but certainly in the general practice it would just be normal kind of psychological support for that we have in mental health services. I don't know if there's anything.
I can answer that. So it's important to recognise that what is the purpose of follow-up? I'm just going a bit of principles here. So obesity is a lifelong condition. I know we treated it like a broken bone, but it's a lifelong condition. And bariatric surgery is surgery that works throughout lifetime. It doesn't work on the day of surgery. And that is quite unique. Therefore, the follow-up is there for safety. And there's 2 types of follow-up. There's follow-up for safety, and there's follow-up for enhancing outcomes. So aftercare is there for safety. It's not there for outcomes. And I know this committee discussed a lot about wraparound care and medications. That is, again, for safety. So we do research, so we know in animal models of bariatric surgery, a bypass still works, just like GLP-1 still works if you give this on a mouse. But the mouse doesn't have to live in a society and it will have weight loss, we'll achieve weight loss. What it will be challenging is to go on through social life, employment, and that's where follow-up is really important. It's not a nice thing to have. So if the anemia doesn't get treated, if the Barrett's esophagus doesn't get monitored, if the blood work doesn't get done, people will get into serious trouble. They will get neuropathies. I have people losing their sight. I have people who are now in a wheelchair. You can't reverse those. You can stop the development, but you cannot reverse those. So that is not an elective thing to happen. We need to have that. We do not provide this globally, and I think it's fair to say that there are constant debate and conflict between commissioners and primary care and secondary care who should do that, because it is a thing that needs to happen. I don't think it needs to happen in secondary care. It can happen in primary care, but it needs to happen. Psychology is much more specialized, and it's, again, not well commissioned. Most units, and I can definitely talk about my unit, we will see people with specialized psychologist support for people who have complications. And people who have bariatric surgery privately or out of the country, there's very little support. So I think that those are the principles, if you like, of having safety first and then enhance the outcomes. And I would argue that psychologist support is a safety net, not a nice thing to have.
In what way?
If patients, so bariatric surgery or acute weight loss of 20-25% is a life event.
Yeah.
Therefore, it will have the impact of a life event. People will talk to you differently, people will see you differently, people will react to you differently. The only thing, and I think you heard it from Professor Taylor earlier on, and I have to say that food is the only bit we have control on. I have no control on the questions you're going to ask me, but I can control what I'm having for dinner. So if that is taken away from me with bariatric surgery, by rearranging my gut or with an injection, that could destabilize me. We also know that people who have had complex obesity very often have a very upsetting sexual abuse history, very often as children, very often as young individuals. When we just take away that weight, that could be massively problematic. I'm just using some examples of how we can help people. So that's not elective to me. Elective is perhaps to offer some support to everyone who has a weight loss journey, but we should be there for everyone who experiences consequences and complications in mental health from obesity care. And that is actually across the board. And I would argue the Pathway to Remission program, in people who will achieve the super responders, who will get 20% weight loss, get 15% weight loss, some of them will have psychological complications, and they will need that support beyond what is provided right now.
Thank you very much. Josh Fenton, please.
Thank you. I'm going to talk mainly about the workforce capacity kind of issues and what we can do. Obviously, you talked about us not having targets for surgical procedures. Do you think we need to get to a point where we do have targets for weight loss surgical procedures?
Yeah, absolutely. I think we should. I think the waiting list should be not just the waiting list. I think the waiting time should be properly managed. I think obesity should not be an exception. So people who have specific levels of obesity should have access to specialist weight management nationally within a time frame which is reasonable, and then undergo bariatric surgery again within, if they're deemed fit and appropriate, within a time frame that is appropriate.
So what I guess also I'd like to get at though, we talk about how long people are waiting, but also, I mean, we've talked about moving from fitness to prevention. If we are going to, and obviously dealing with weight loss prevents further illnesses. Do you think we also need to look at the number as well, the absolute number, not just how long people are waiting, and perhaps look at increasing that?
How many we should be doing?
Yeah.
Absolutely. I should also tell you something about waiting. So waiting is harmful. So we have clinical trials on that. So if you take 1,000 people that qualify for bariatric surgery, and you let them wait for a year, 8 of them will not be here. Right. So 0.8% mortality is the waiting time price for bariatric surgery.
So waiting
zero. People die.
Not a neutral within itself. Okay, so I'm going to just move a bit on to that. So 21-22, we had 4,400 surgeries. That moved up to 6,900 by 24-25. But obviously, as I alluded to just now, it's nowhere near the 28% of adults who are obese. Now, I appreciate that bariatric surgery is not the answer for all of those adults, but do you think it is the lack of an experienced workforce that is holding us back from doing that?
So if you don't mind, I'll just make a comment about the language. I'll say that people are not obese, and I know I've heard this before here, and they're not diabetic. They're not defined by the disease. They just have the disease. And I'm not. Everyone else has used it, including people on this panel. So I'm just sort of putting it for the record. So people living with obesity, there are millions, as you say. We don't need to treat with bariatric surgery 28% of them. I think we need to offer care to enough of them. And that is across the board. And if we do that, we will find that bariatric surgery numbers will go up. I do think we need to recognise that we have a very low figure. And as I said, the first target will be 20,000, and that should happen immediately because we have the workforce for that. And I think if we need to go beyond that, we need to start building the infrastructure for that. But we need to have a target of how much surgery should we be doing
Hang on, just pause. You think we have the workforce to deliver 20,000 bariatric surgeries a year?
So I may have said this.
Three times what we're currently delivering.
Yes. So I'm going to repeat myself if that's okay, because you may have missed this. I mentioned that calculation earlier on. So back on the envelope, there's 160 surgeons in this country delivering bariatric surgery every year. If they work 40 weeks. So they have time for annual leave and time to come to parliamentary committee meetings. I even make the same joke earlier on, so you haven't missed out. And if we ask them to do 3 operations a day, which is highly achievable, I do 3, by lunchtime in Bristol, you're able to deliver 20,000 tomorrow without any change. You need theatre, and I think Neil mentioned that earlier on. You need theatre time, and you need prioritisation of that, but you don't need new people to deliver this immediately.
That's really useful. Going back to Dr. O'Brien's testimony earlier, obviously he talked about kind of need for more expertise and need to go down a kind of look at it as a specialty kind of weight loss treatment. The Royal College of Physicians believes it should either become a specialty pathway or kind of further than that. Do you think there is enough to make that it's a weight management its own separate specialty pathway?
So obesity management and the medical management of obesity has been included in the training of subspecialist endocrinology doctors for some time, since about 2012, 2015, something like that. And there's certainly calls to make it part of the integrated medical training for all kind of consultant physicians. I think we also need to upskill the GP workforce as well to have further knowledge in this area. So I think in order to get so it should be a subspecialty on its own. I think there's the work there for it, there's the demand there for it, and there's a lot more new treatments coming on. Just going back.
Can I just ask why you don't think it should be its own subspecialty?
Well, it can be. I don't see that there's not a big problem with it, but currently it's a subspecialty. Usually the diabetic specialist doctors who work into obesity medicine. So I mean, there's a huge amount of work to be done in the complex management of diabetes as well. So we just need to be careful not to subspecialise the profession too far.
Yeah. I mean, I guess I was looking at it, and certainly a lot of the procedures are delivered by SAS and LE doctors, and obviously you want to do more to allow those people kind of clearer career paths in weight management.
So another way of seeing that, and I can say this as a secondary care doctor, is that obesity is a disease that is affecting so many people that cannot be too specialised. How can you be an orthopedic surgeon fixing people's knees and not knowing about obesity? How can you be a respiratory physician dealing with people's asthma and sleep apnea and not knowing about obesity?
I will get into that, because that's actually my next question. But I'm just kind of I'm trying to think about just in terms of just knowing NHS structures as I do. Kind of what specialised is valued in a lot of ways. And I wonder almost whether there's an argument for kind of obesity and weight management credentials or something like that within, now that the GMC are opening up more credentials pathways. Do you think that might be a way forward and something that is more encouraged, and it's encouraged that more trusts have people with those skills?
Well, I would use exactly the same example used earlier on about other epidemics. So we all became COVID-19 specialists for a period of time. Why can we not do this for obesity? If it's affecting, it's not a rare disease. We're not in a rare disease space. If it's affecting 30% of the population, even higher if you're in the Northeast, how can we not get credentialed on that? Absolutely. I think it's a really good way forward.
Yeah, I think kind of it's comorbidity for so many deaths as well. Kind of thinking about the dying with element of COVID, it's a really, really apposite point. So moving on, what more can we do to make sure that in terms of all of medical training, the weight management and kind of the different aspects of treatment are incorporated, so that when you, as you say, when you deal with your knees or your sleep apnea, you are more likely to be referred down an effective weight management pathway. How can we better improve medical training on that?
First of all, and I appreciate there'll be outputs from here, I tend to use the word obesity care as opposed to weight management, because you can argue that This is much more sort of personalised and humanising. So I think we need to have obesity care everywhere, and I would start with medical school. That's where you have the biggest impact. And I would argue that every medical school, and I know this from my medical school days, I was asked conditions that I've never seen, but my children will not live as long as my parents because of obesity, and people get one lecture in the whole curriculum. So I think that needs to start in medical school, and I think there could be a national standard on that.
Is that still the case across all medical schools? There's one lecture?
Well, it's very little. I'm sure it's the same in the North East, but there is no clear strategy in including obesity as a mainstay of treatment, as a mainstay of education for the doctors of tomorrow. Absolutely. We don't do enough, and I have visibility, have a bit of a global view on that. People are trying to work on it. We don't do enough. We haven't. And I think Neil mentioned that earlier on. The evolution of medical education is a slow process. We're still learning things that people studied 200 years ago. So we are taking time for something to get into the medical school textbooks. It takes a bit of time. Yeah. But we don't have time with obesity. So I would argue that needs to happen at medical school, then credentialing, and I think you can argue that registration is a really good process for that. And then it needs to be included in all the exams, primary care, Royal College of Physicians, Royal College of GP, Royal College of Surgeons. Maybe we should all be asking more questions on obesity.
And is it, do you think it's something that we should expect people kind of on their ongoing improvement to continue to keep abreast of the, I'm thinking specifically about GLP-1s and things like that. I feel like there are doctors who have trained further back in history who just aren't ready to deliver them and the associated care.
You're absolutely right, and again it goes back to the stigma question. So you wouldn't accept me delivering cancer care with information I have from 25 years ago. You wouldn't tolerate me as a cancer specialist if I haven't been in the conference for like 5 years and I still do what people did in 1993. But in obesity we tend to do that. We still give the same advice people gave in 1993. And that has to change. Absolutely, we need to keep asking those questions.
Dr. O'Brien, I'm just thinking, obviously you've got a slightly broader view because you've got the practice as a GP. When you think about people going into a GP's office, what are their chances of having a GP that has that knowledge of healthcare in this area?
I think the chances of coming across a GP who's got confidence to adequately advise someone on all the treatment options that are out there for obesity management now are pretty slim. I think there will be some GPs who have an interest, who will be quite comfortable in prescribing in these areas or know the criteria for access to bariatric surgery, but it is not universal. So I think if we're looking to try and fix the access issue, all patients access these treatments through their GP. I think we need a very focused effort and prioritised education for GPs if we want to improve access in the short term.
Brilliant. Can I just ask what kind of debate is going on between physicians on this? Because my knowledge and bitter experience of medical schools is they don't love politicians telling them how they should design their curriculum. Do you think there was enough debate within the medical community about this?
Probably not. And perhaps you make a very strong point here, which is the education piece around obesity does not need to be it's not massive. Most people actually think, the issue with obesity is not that people don't know anything about it, is the fact that people think they know about it. And they probably have misplaced views on this. And I always use the example that, in my next life I'll be a cancer specialist because, my train to hear, if I said I was coming to a cancer committee, nobody will say, I know this, you don't need to have a degree in this, I know how to treat cancer. But most people will say, I know how to treat obesity because my cousin had this diet over the internet and it worked. And I think that's the aspect of education we need to look at. So challenge the dogmas, get the actual science there, ask those questions as opposed to a very detailed physiology and anatomy and biochemistry lesson. I don't think people need that. And I would argue that what should be national policy, and maybe regulators as the GMC is a good place to do that, or medical schools need to do that, is that they are treating obesity as a disease. They don't need to have 10 lectures instead of 1, because that becomes tokenistic. So if you ask me to do my mandatory training, just like I do the fire safety lecture that I have to do something on obesity, I'm likely to tick a few boxes, but you're unlikely to change my view on obesity. I think we need to do to do the opposite. We need to challenge people's views and destigmatize the condition with education.
Yeah.
Thank you.
Thank you. Right, I'm sorry, colleagues, I have one very last question, because in the 10-year plan, you'll know that there is this moonshot, and I quote, to end the obesity epidemic. And they point the way by talking about new innovative approaches to treat obesity through the Obesity Pathway Innovation Programme. Out of 10, given that this programme exists and on our current trajectory, what do you give our chances that we are going to end the obesity epidemic in 10 years' time? Neil?
That's very ambitious, I think.
Ask for a number. Number, please.
Out of 10. Within 10 years,
yeah.
I would say I'm currently feeling around about a 3 or a 4.
Lovely. 3 or 4? 0. So let's try and, what would shift the dial upwards? What advice, if they want to do this, they've written it in, and we all know to get any line, anything in a plan like this takes some ambition of itself. But what would shift? What would make your 3 or 4 or 5, or what would make your 0 or 2? Neil.
I think we need to, I think viewing obesity as a disease and treating it that way in a structured way might give us a chance, as not ignoring all of the foundational work that needs to be done around food and the and exercise and the behavioural programs.
So it's recognising that we need to do prevention, which is we're good at, and it's much more politically palatable, prevention, and we need to do treatment. And the reason this will never work is because you can't end an epidemic in 10 years. But what we can do is we can start getting better prevention strategies. But what we do uniquely for obesity is when we talk about treatment, the discussion gets derailed to prevention. So if I was here talking to you about chemotherapy, nobody would ask me a question about the smoking ban. And if I'm talking about trauma surgery, and I do a lot of that, you don't tell me if I go to school to tell people to stop carrying knives. But you want me to do the right thing for the patient in front of me, and you want me to give people good chemotherapy. In obesity, we talk about GLP-1s, we talk about bariatric surgery, and then someone says we need to fix the food environment. Absolutely we do. But that will only stop the increase of the epidemic. That will stop the children born today, and I'm amazed about this smoking ban. I think it's fantastic that children born today will not get to smoke, but I still have lung cancer that I see every day in my clinical practice, and I have to treat that. And nobody questions if those patients should get chemotherapy. And that's what we need to do for obesity.
Thank you very much. On that we end. Order, order.